So I am Sarah. We are a new organisation, so we are a newly formed, merged organisation across Hampshire and the Isle of Wight, providing community and mental health and learning disability services across quite a wide geography. We're one of the largest providers now across England, and we are very much finding our feet. However, have a huge amount of enthusiasm around research, capability building and how it links with effectiveness and continuous improvement. Our research and improvement infrastructure is sort of run through our Academy of Research and Improvement. We have very deliberately integrated different activities related to research, improvement, clinical effectiveness. And Shira, like, you made my heart sing, because it was like all the stuff that I've been banging on about, and people look at me like I'm barking mad trying to integrate it. You would talk to it exactly as we've been thinking. So thank you. Brilliant. And we'll be coming up to visit you. So our academy looks at, so it integrates clinical effectiveness, research, quality improvement, really strong participation thread, and the whole point is about building a learning health system, exactly the same, which is highly networked, so that across a big geography we can work in partnership with people outside of our organisation, with the people that use our services, with other colleagues, to try and build this kind of thriving, learning organisation, which is really evidence-based, but importantly that we can help the people who are delivering services to work in partnership with those that are using them to kind of continuously learn and improve. Now that might be research, but it might be all sorts of other activities which lead them into them. We have some clinical research facilities, so obviously we do all mental health, so we do clinical trials, but we also have community participatory peer researchers, and at the moment we have kind of 4 bases, I suppose, across that geography, so we're quite well distributed. You'll notice that we're not too strong up in the Basingstoke area, but we're working on it. And we now have a kind of a big kind of delivery research team of approximately 60 people who are supported by people who are distributed across our clinical services and across our community services and sort of partner organisations as well. We work very strongly with community organisations, so we've got colleagues here from Portsmouth City Council, Southampton Voluntary Services. We have school networks. We have a care home research partnership, which is all about how do we work together to deliver research, rather than can you just send me some people to participate in my trials, which I think is a really different way of working, which we really enjoy. Where we want to get to. So I firmly believe that doing research in the community and building an evidence base to support the left shift or the 3 priorities is different. It's not the same as running very controlled clinical trials. We often talk about how it's a bit messy in the community, gloriously messy, but that means that, you know, the old traditional methods don't necessarily work, and it has to be much more controlled, shall we say, and there's lots of different ways of learning and building an evidence base, and I think we're really seeing how that's shifting. The HDRC, so the Health Determinants Research Collaborations in the 2 city councils are really helping to kind of push that message about community evidence as well. But what would be really helpful to us, and I think that's what this conversation is about today, about how we can work more collectively together, is some real collaborations and academic collaborations. We have such fantastic infrastructure, don't we, across Wessex. So we have Wessex Health Partners, we have our ARC, so on and so forth, where we can really start to collaborate across boundaries and not worry about which organisation we work for, but actually how we can work together to kind of build that evidence base and get loads more people involved in research, and also to have some I think we can do a lot more in the space of what are the priorities, what do we need to know, whether we do that through an effectiveness route or an improvement route or into a research route. What's the kind of collection of evidence so that we can demonstrate really clearly that actually delivering care in the home or out in the community, not in a hospital, is really effective, and we can really empower people to take control of their own health and kind of live better for longer. We're going to talk about linked data later, but data is one of the challenges, I would say, in terms of how we can put it together and how we code, and it's great in primary care because it's all properly coded. In other services that we deliver across the community, people input data really differently, so pulling it out is a real challenge. So how can we do all that kind of data literacy and that capacity and support for people to understand that the way you put data in is really going to impact how you get it out, which for us we'd really like a kind of support with, or to work in partnership with. And then some real world, messy, learning evidence research that fits the communities in which we work rather than some very controlled approaches. And of course, to be very person-centered, to think about who's not in the room, how we're addressing inequalities. I love the thought of the edge data being matched, because we hadn't thought of that. We were trying to collect it all ourselves. Genius. Let's do that. Yeah, just to make research more fun and more useful to most of us, yeah, rather than really controlled. I think that's it. Yes, very fast. On track.